Thank you. I'm very happy to have the honor to do this Enrico Greppi Award lecture on behalf of the Trigeminal Neuralgia Research Group from the Danish Headache Center in Copenhagen. And on behalf of the group, I would like to thank the selection committee for selecting our paper for this prestigious award. I'd also like to thank the co-authors to this paper, and a special thanks to Professor Jess Olesen, who also contributed in developing this management program. I'll go through the paper Trigeminal Neuralgia, Coherent Cross-Specialty Management Program, as well as I'll go through the other scientific results that the group has achieved over the last 3 years. Lastly, I'll give you some future perspectives on the trigeminal neuralgia research that we believe will be interesting to focus on. I have nothing to disclose. I believe the majority of you have met this woman, or she could be a man, a patient in your clinic that suffers from excruciating stabbing pain in one side of her face. She's not able to talk or brush her teeth as it triggers the pain. You might have initiated the treatment, giving her the diagnosis, or referred her to colleagues because you need a second opinion. If you're a dentist, the patient might have forced you to do invasive treatments on her, even though you thought the indication was weak. Traditionally, the management of this patient group lies in the hand of many specialties, such as neurologists, anesthesiologists, neurosurgeons, dentists, general practitioners. And we know that that has led to some inconsistency in diagnosis and treatment, and might have led to misdiagnosis and incorrect treatment. Previous research has shown that there's a long diagnostic delay for this group, and they can suffer for many years before they get the diagnosis. Up to 1/3 of the patients have invasive dental procedures unnecessarily done before they have the diagnosis. And we know that not all are offered MRI as a part of their workup before they get the diagnosis. And lastly, we know that there's some inconsistency in the follow-up of the patients. And it's our clinical experience that the patients that are neurosurgically treated not always are followed up afterwards, maybe a couple of months, but not for a long time. They might develop complications to the treatment, or they might have a reoccurrence of the pain. So the background for doing this study was that with increasing clinical experience and due to comments from the Danish patient group of trigeminal neuralgia, we thought that the management of this patient group was very inconsistent and highly variable. And we thought that a formal collaborative effort between neurologists, neurosurgeons, and neuroradiologists was needed to handle this inconsistency. So the aim of this paper, Trigeminal Neuralgia, a Coherent Cross-Specialty Management Program, was to describe the implementation of this management program and describe the feasibility and how we did the collaborative effort between the 3 specialties. The 3 main aims of the paper was to describe the implementation, but we also want to show what was the patient flow the 2 years after implementation of this program. And lastly, we wanted to create a discussion of this, how to optimize management of this patient group that suffers from this debilitating disease. So in May 2012, we developed and implemented this accelerated management program, where the key points are that they're all seen in an accelerated manner. Patients that are initially directed to Department of Neurosurgery are redirected back to us at the Danish Headache Center. That is to ensure pre-surgical evaluation of the diagnosis, as well as optimization of the medical treatment. We also ensure standardized workup with clinical interview and examination. We ensure the correct diagnosis using the diagnostic criteria, ICHD3 beta diagnostic criteria. We also have a special MRI protocol a 3 Tesla protocol that is evaluated by a blinded neuroradiologist. The treatment is according to the AAN and EFNS guidelines, although somewhat modified and some might say conservative. We want the patients to have tried at least carbamazepine, oxcarbazepine, and the best sodium channel blocker plus an add-on before we believe they're medically refractory. If they're medically refractory due to insufficient effect or intolerable side effects, we refer them to Department of Neurosurgery. There, the neurosurgical treatment options are microvascular decompression if a neurovascular contact is found on the MRI. Otherwise, they will be offered balloon compression or glycerol blockade. For all patients, we are following them for a minimum of 2 years, and that again is to ensure that we have an optimization of their medical treatment and that we can follow the patients that are neurosurgically treated if they develop complications or they get the pain. So 2 years after implementation of this program, we can report that a total of 207 patients was referred to us with the possible diagnosis of trigeminal neuralgia. Approximately 1/3 had their diagnosis changed to other diagnoses than trigeminal neuralgia, and the majority was persistent idiopathic facial pain or symptomatic trigeminal neuralgia. A small group was also referred with another diagnosis than TN, and there we changed the diagnosis to trigeminal neuralgia. A total of 130 patients was entered into this accelerated management program, and 2/3 of these was continuing their medical treatment. The last third was referred to the Department of Neurosurgery. 67% of these was treated with a microvascular decompression. But we had a special concern for the patients that was entered into this redirection path, saying that the patients that were initially referred to the Department of Neurosurgery, then referred to us at the Danish Headache Center, and then we thought that they were actually medically refractory, and then referred back to the Department of Neurosurgery. What would happen to these? Would we prolong their diagnosis and the initiation of the correct treatment? Going through the data, we saw that 25 patients was redirected from Department of Neurosurgery. They went through all the assessment points that I just showed you at the flowchart, and almost half of them was directed back to neurosurgical treatment. All that was done with a median waiting time of 3 weeks. We believe that this waiting time is acceptable, given that these patients had been suffering from trigeminal neuralgia for an average of 7 years before they were referred to us at the Danish Headache Center. This is also given the fact that the other half was actually managed well with medical treatment, so they didn't need neurosurgery. So the experiences after implementation of this management program is that we have improved the management of this patient group. And this is according to initial feedback from patients and clinicians. We also think that these are acceptable waiting times, at least that the Danish Headache Center is a public tertiary referral center for headache and facial pain, and there the waiting times can be very long. So the waiting times for this trigeminal neuralgia group was from referral to first outpatient visit was 6 weeks, from outpatient visit to MRI was 5 weeks, and from the first outpatient visit to referral for neurosurgery was 9 weeks. And this is the group that was not redirected from Department of Neurosurgery. And this accelerated optimization of the medical treatment actually ensured quickly referral to neurosurgery if the patient was medically refractory. We also ensured standardized follow-up also for the neurosurgical treated patients. And lastly, we found that this setup was very good for collection of important scientific data. The collection of these data has led to a database that currently consists of 381 trigeminal neuralgia patients, where data has been collected in a structured and prospective manner. And it's on the basis of this database that the research group has been able to publish 6 peer-reviewed papers over the last 3 years, first and foremost due to the excellent work of PhD student Stine Morbjerg and Associate Professor Lars Bentzen. The group has described the clinical characteristics, described concomitant persistent pain, field-tested the diagnostic criteria, and also described the neuroanatomical abnormalities. Lastly, this was published in Brain, and one of the main conclusions of this paper was that it's not the matter of the neurovascular contact being present, it's the matter of the severity of neurovascular contact. And this MRI shows that the patient has a neurovascular contact on both sides, but the one that is shown with the arrows actually shows a displacement of the trigeminal nerve. So severity of the neurovascular contact is highly associated with the symptomatic side of trigeminal neuralgia. So conclusions of 3 years of research is that the cross-specialty management program is feasible, and we're the first one to describe a management program like this. That there's a high prevalence of concomitant persistent pain, autonomic symptoms, and sensory abnormalities. That concomitant persistent pain is not a consequence of long-standing paroxysmal pain, and that severe neurovascular contact is highly associated with the symptomatic side of trigeminal neuralgia. And lastly, all these papers was also to create awareness of this debilitating disease. And as I said in the beginning, we wanted to stimulate discussion internationally about how we can optimize management of trigeminal neuralgia. But there are other aspects to the research of this disease, and currently we are conducting other studies, and we're doing a study of quantitative sensory testing together with Professor Ralf Baron in Kiel. We're also doing a study on genetic predisposition together with Katharina Faber and her group in Maastricht. And then we're doing a prospective follow-up of the outcome of microvascular decompression. And there the patients are seen by independent assessors. That's done together with the neurosurgeons from Rigshospitalet. Lastly, we hope, and we're doing a pilot right now, to conduct an international multi-center study of outcome of microvascular decompression. And that's done together with a couple of neurosurgeons in Sweden, as well as in the UK. So, the last 2 studies that I just summarized here are very much needed. We need this structured studies. And we hope by conducting this research together with the existing results that I just presented to you in this lecture, that we can translate the scientific evidence into clinical practice, so we can optimize the management, the treatment, the diagnosis, so we can be sure that these are actually suffering from trigeminal neuralgia, and we can give them the correct treatment. So this woman won't be suffering, and all the other patients suffering from trigeminal neuralgia. Thank you.